Hey, I'm Dr. Dino Pappas. This is a quick 5 to 7 minute orthopedic exam that will constitute orthopedic testing, some neurodynamic testing, and some functional testing of the shoulder. The first test that we're going to do is we're going to do all these tests here on the table. So we're going to do a median, a radial, and a ulnar neurodynamic test. For a median neurodynamic test, we're going to open up the hand and arm, going to extend the elbow, and we're gradually going to take the arm up into about 90 to 120 degrees of abduction here, really stressing that median nerve. Next test we're going to do is a radial ulnar dynamic test. We're going to internally rotate and we're going to pronate the forearm. We're going to bring the wrist back. We're going to slowly abduct the arm, looking for symptoms along the course of that radial nerve. Then it's the ulnar nerve. We're going to bend the elbow, extend the wrist. We're going to bring the arm into about 90 to 120 degrees of abduction, bring the arm all the way up on top of the head, looking for symptoms along the course of the ulnar nerve. This one's particularly important when they have ulnar neuritis or they have some symptomatology at the medial elbow. So the other test that we're going to do is Hawkins. We're going to bring the arm up into this position, drop the elbow, and internally rotate the arm, looking for symptoms of subacromial impingement. That's symptoms right here inside the shoulder joint, possibly referred down to the tip of the shoulder. Next test is Neer's test. We're going to internally rotate the arm right here, thumb down. We're going to bring the arm in the overhead position, and we're looking to cause compression right here in the shoulder. Again, signs of subacromial impingement with an internal rotation mechanism. Next test that we do, I call this the shoulder clearing test or the crossover test. We have the patient's wrist on the opposite shoulder. We pin that down. We have them lift that elbow all the way up towards their head, looking to create compression with the mechanism of internal rotation, elevation of the arm of subacromial impingement. After that, we do something called a modified dynamic labral shear. We stabilize right through here, and we internally and externally rotate the arm with a little bit of stress, looking to aggravate the labrum, the lining of the shoulder joint. I mix this traction with compression of the joint, where I'll compress the joint and have the same symptomatology, trying to reproduce clunking, grinding, or pain deep inside the shoulder joint from that position. The Clunk grind test, we take the arm up to above 90 degrees, between 110 and 120 degrees, add pressure, and internally and externally rotate, looking for grinding, clunking on the labrum. This test is basically trying to check for an internal structure that's getting aggravated. From that position, we're going to go into our apprehension test for anterior instability. Anterior instability will locate pain here. They may not even let us go into that position of apprehension and fight us. If they do have a positive apprehension test, we recommend confirming that with a relocation maneuver, where we translate the humeral head posteriorly and then repeat. And if pain goes away with this maneuver, that's a good sign that it's true anterior instability rather than an internal impingement. If we do this test and they feel it back, they feel it back here, we relocate the humeral head and they feel it again in the back of the shoulder, does not change the test. That would indicate an internal impingement, namely of the labrum here in the posterior side. So do make sure when you do an apprehension test, you follow that with a posterior glide of the humeral head, looking to see if the relocation maneuver will reduce symptomatology. We're going to get you up. We're going to do a couple tests with you in the sitting position. From this position here, we're going to take the arm up to about 120 degrees to 130 degrees of abduction. Internally rotate so the palm is facing this way, pronate. I'm going to have you bend your elbow against resistance towards your head. This is again called testing the biceps load and shift test. We're testing the biceps that comes into the shoulder joint, looking for a labral lesion where the biceps attaches. You can do this from an internally rotated and pronated position or from an externally rotated and supinated position. Go ahead. So stresses slightly different tissues from that position right through there. Okay, we'll go into our tests of the rotator cuff. This is in the scapular plane, thumbs on up. Resist, don't let me push down. And we compare that to thumbs down, don't let me push. Slightly different stress through the muscles of the rotator cuff based off of the position. I like to do it from the scapular plane. That's more of a natural plane to get a positive test. Scapular plane is right about here. This is the frontal plane, this is out front, this is the sagittal plane, this is the scapular plane. From that position, I like to do the painful arc test, where I have them lift their arm all the way up. Typical pain with the rotator cuff is approximately between about 80 to 90 degrees of abduction to about 120, 130. Typically it gets better closer to the top. Whereas an impingement is typically worse when you get above 90 degrees and worse as you get towards the top. The arc is painful from here to here, then typically dissipates and go away. I also like to observe the arm coming down as in a drop arm test. If they have weakness with eccentric control, it's indicative of rotator cuff pathology right back through here. Let's put your hands on your abdomen, and I want you to keep your hands pinned down. I want you to bring your elbows forward. Typically on a positive test with this belly off test, one arm will lift all the way up off of the abdomen if it's a positive test for the subscapularis, the internal rotators. Let's bring this back behind. I want you to lift this arm up off of your wrist up off of there. This is a belly off test. From this position, we can actually test strength. Go ahead and resist this. And as we do that, we're testing the subscapularis muscle for any tears or lesions of the subscapularis. Let's follow that up with a couple other tests while the patient's in the sitting position. Rotator cuff testing at 0. Hold it. Don't let me push. Hold it. Don't let me push. External and internal rotation. Bring your arms up just a little bit. Hold it. Don't let me push. 45 degrees in the scapular plane. Just slightly different tests and slightly different force from the muscle. Let's bring it all the way up to about 90 degrees. Don't let me push. Don't let me push. Again, just testing the rotator cuff at multiple planes of motion just to see if there's any weakness in that position. Moving into speeds test where the patient is right here. Don't let me push down and in. The biceps elevates. The biceps tendon also supinates as well, so we're testing the biceps tendon. Bring that across. Hold in this position once again. Now turn the thumb down. This is O'Brien's test for the labrum. Hold it, don't let me push right in this position. This is looking for the labrum, all right? Stressing the biceps tendon as it comes into the labrum in this position here, all right? So first start with speeds to obtain a baseline, then bring it across the body into horizontal adduction, then rotate here, and often you will find weakness and pain in this position. You may even hear a clunk or a grind with that test. Going into the elbow, the last major thing in the body. Hold your wrist back in here. This is testing for lateral epicondylopathy. Bring it forward, curl it. Don't let me push. This is testing the medial elbow right through here for medial epicondylopathy. To follow that up, bring the finger back, hold that. This right here is called Mosby's test. It's typically positive for lateral epicondylopathy, whereas hold this right here, don't let me push these fingers apart. That's a test for the radial nerve, all right, since this is innervated by the radial nerve. You often will find that positive with radial neuritis. All right. Far more common in the thrower is the medial elbow. Let's go ahead and have you flip around right here. The test for the medial elbow is a straight valgus, testing the ulnar collateral ligament. We can even put this in flexion, taking it into extension and rapidly hyperextending and adding a force to that, which put even more stress, mimicking the pitching and throwing motion where this is extremely vulnerable. Move back one little bit. We can even do the milking maneuver. Milking maneuver is, again, more of a dynamic test where you get the patient in the throwing position and you're checking not only for pain and discomfort, you're checking to see for laxity of the ligament in different positions. Sometimes you'll even feel that give underneath your fingertips. It's highly recommended that you actually palpate the medial elbow while you do this test. All right. Outside of the milking maneuver, some other tests for the elbow would include stressing that ulnar nerve right through here that we mentioned with an ulnar neurodynamic test. Last one are the functional tests. Let's get the patient up. Let's put the patient on all four hands and knees. And if we can observe scapula, we call this the 4-point rock maneuver. We see a little bit of winging right through here. Go ahead and rock your body weight forward and backward. Notice how we start to see the rhomboid muscles here retract the scapula. We see lack of inferior trapezius stabilization and lack of serratus anterior function. So this is a nice dynamic test of what the scapula should be. Is it protracting? Is it retracting? Is it stable up against the thoracic spine? Now go ahead and go laterally. We see even more winging in this position. Again, this is a test of scapular stability. We note the increased tension right through here in the rhomboids, and we also note that winging, lack of the protractor serratus anterior doing its job. Okay, let's have you drop down into a modified push-up. Drop your knees back, and then go ahead and push your body weight up. Keep your knees down. Good. Again, looking to see what happens to the scapula. Go ahead and go down into a modified push-up. Notice the retraction there. The scapula is not flush with the thoracic spine and the rib cage. Okay. Last two tests. Let's get you up. Let's put you up against the wall. Face forward, all the way. Let's have you lean back up against the wall. Good. What I want you to do is I want you to lift your thumbs all the way up towards the ceiling. And what we're looking for is what's going on in the abdomen. I see a little bit of splaying of the abdomen indicating loss of stability of the anterior core muscles. Are the thumbs making it to the vertical plane? If not, it could indicate latissimus, tension here in the latissimus dorsi. I'm also monitoring pec tension. I'm also checking to see what happens here. The lumbar lordosis right back here increased, which typically indicates loss of abdominal control coupled with loss of thoracic extension. So thoracic spine, abdomen, latissimus, and pecs are what we're checking. Okay. Scoot a little bit forward. This is the angel. Call this a wall angel position. And what we're looking for here is we're looking to see if the wrists make the wall indicative of pec tension or internal rotation, internal rotator tension, and she does make it to the wall. We're looking at the interior abdomen. Is she being able to keep this position with the rib cage pinned to the pelvis? Again, abdominal control. And does she increase the lumbar lordosis right through here? Can she keep this in a nice stable position? So this is the wall angel position. And that's our orthopedic exam for the thrower. Thanks.